Today he'll be sharing insights on how we can increase health span for everyone, not just in advanced economies, but across the world. Please join me in welcoming Dr. Mehmood Khan.
Well, good afternoon. Salam alaikum, namaste, whatever your greeting is. It's truly a pleasure, an honor. My first visit to this part of the world, and what a beautiful place to live in. I'm truly impressed. I'm going to talk to you about the work we're doing at Hevolution, and actually, I would say it's the work that is being done around the world that we as Hevolution and my team have a chance to support, promote, accelerate where we can. So really, this represents the work of many of the speakers included that are going to follow. So my job is sort of the warm-up to what you're going to hear. The field of aging research is centuries old. This is something that is not new, and over 100 years ago in the UK, scientists started to ask the question, not about the elixir of youth, but how do we understand aging as a biological process? And of course, there have been seminal landmarks that have happened. The fundamental question that still remains is, how's it going to change and impact humans? When we were created, and the vision of His Royal Highness Prince Mohammed, the Crown Prince and Prime Minister of Saudi Arabia, to whom, who is my chairman and I report, was very clear, which is we're not focused on extending life, we're focused on extending healthy life. And that's an important thing, as you can see on this slide. This is about health span. This is about how long we stay healthy, not how long we live. And if it means that life is going to get extended, so be it. But that's not the primary goal. And that's important because a lot of people confuse the two as the same thing. Very quickly, where are we today? Very straightforward. If we look around the world, years of life are about 73 years on average. We spend about 10 years of our life with disease, with increasing decline in our body functions. Wherever you look in the world, it's about 10 years. Africa has one of the shortest life expectancies in the world, but still at the end of the life, about 10 years is spent with disease of some that you've just heard about: diabetes, cardiovascular disease, age-related cancers, etc. This, of course, was not always the case. The way we used to think about the world was a lot of young people supporting the lives of a few older people. That has changed. Here is the changing population demographics as we look around over the years, men and women shown as we see. The world's population is getting older. That pyramid has become a cylinder, and of course is projected to become an inverted cylinder. Fewer and fewer young people, a lot more older people. And the question that is posed now to most leaders is not a science question. It's a socioeconomic question, which is, how is society going to support this growing population of older people, which today we have 1 billion people over the age of 60 around the world? By 2050 or so, it's going to be 2 billion. The world's population is not going to double, but the dependency ratio, that is the number of people, if young people have to take care of, is going to itself dramatically change. And that is what Hevolution has been focusing on. How do we think about this from a global challenge, and what are the solutions? I'll talk a little bit about how we do this, but something on Mauritius. Not surprisingly, for a developed economy, which is really, Mauritius has to be congratulated. It is a standout in this part of the world in terms of how the economy has been developed. It's a strong economy, good infrastructure, good health systems, but look at your population demographics. What has changed dramatically is a population that is now aging in place, and with it, the diseases that come. This is not just unique to here. I can tell you, for example, in the Middle East, we always think of Saudi Arabia, the Gulf countries, as a young population. That is true. The population of Saudi Arabia today, 50% of the population is under 25, 60% is under 30. 2/3 of the population of Saudi Arabia is under 30. So you think, why would Saudi Arabia think about aging? The reality of it is the birth rate in Saudi Arabia used to be about 6 children per couple. Today, it is 2.7. The replacement rate is 2.17. We are very close now, where Saudi Arabia's population is about plateauing. It will then do what is happening in Mauritius now, where the projection for Mauritius is for the next 15, 20 years, the population will start to fall, and by 2050 is expected to significantly fall for two reasons: a declining birth rate and increasing life expectancy. So the good news is public health systems have been successful. The challenge they've been created now is how do you deal with this? Europe is dealing with this, the United States is dealing with this, the UK is dealing with this, but this is the implication from a health system point of view. If you look on the left here, you will see that if we look at age on the horizontal axis versus diseases on the vertical, look what happens. Around age 40 or so, the risk of diabetes starts to go up. We've seen that already in Mauritius. You're seeing it. We're seeing it in the Middle East. We're seeing it across Asia and Europe, North America in particular. Somewhere around age 50, you start to see cardiovascular risk and cancer around age 65 onwards suddenly takes off. So as your population increases, this is what is to be expected if we do nothing else. And of course, it's not one disease. They're all dramatically, exponentially increasing in risk. And that is a challenge for healthcare systems. This is not unique, but the opportunity is how do we address this without what you see on the right side. On the right side, you'll see healthcare expenditure on the horizontal axis versus adjusted life expectancy, or if we think about it, health adjusted. Right? What's the ROI? And if you see on the vertical axis there, after about $2,500 per person, there is no increase in return. In other words, spending more in the health system doesn't change that variable. And so always, all the way to the right, that one dot you'll see on the right is the United States. Then you see Europe, etc., and all the way to the left you'll start to see, yes, there is an ROI by increasing health expenditure for the population, but it rapidly plateaus. And so this is raising the question with ministers and leaders, no matter where you are in the world, how do we address this and get a better ROI for our healthcare dollar? Because what we're doing today isn't working. If you look at the United States, Medicare has become unaffordable. If you look at the United Kingdom, the NHS is not viable financially. Look at Ireland, look at Europe, you're getting the same questions raised. How do we address this? It's up to not only politicians and policymakers, but us as clinicians and scientists. What is it we can do differently? And that is what Hevolution has been asking. And if you think that this is something that is of concern just in this part of the world, no matter where you look, populations across the planet, Asia, Middle East, Europe, and North America, the same phenomenon is being experienced. In some countries, it's more acute. South Korea has a declining but aging population overall. It's declining. The birth rate is less than around 1.5. China, of course, their one-child policy has caused the same challenge. Japan, 1 in 3 people in Japan is now over the age of 60. That's a third of the population. And so the number of taxpayers who are available to support that population has been declining. It's an economic crisis, amongst others. Quick analysis of Mauritius. As we look at this, you just heard this, non-communicable diseases are responsible for about 1/10 of the population's deaths right now. Diabetes, about 15%, and of course obesity, 1 in 5. It's not where we see things in the Middle East, where they're almost double those numbers, but that's where things are heading as we look to the future. If you look at Saudi Arabia, it's one of the highest rates in the Middle East, 32% non-communicable disease. 1 in 3 Saudis now have a new non-communicable disease and are responsible for 3/4 of the deaths in the country now. And that is the health crisis. These are age-related diseases that are occurring earlier. And that's the message. We've defined age-related diseases based on your birth certificate. What we're seeing is some populations biologically age faster than other populations. The Middle East, South Asia, India, people of the Indian subcontinent like myself and many of yourselves who are of that genetic origin actually age faster. What I mean by that is the same disease that expresses itself in Europe and North America actually occurs about a decade, 5 to 10 years younger in our populations. So we have to rethink what is the impact of time in the environments that we're living in. Our genetics versus the environment we're looking are actually not correlating in a positive way. So what is Hevolution? I'm going to talk a little bit more. Hevolution was created with this in mind. We're a global nonprofit organization Today, we fund, and we'll talk a little bit about the different areas. We have 4 areas of focus. We fund research across the world, academic, predominantly in either research centers or universities, and I'll talk a little bit about how that is going on. We invest private capital, but 100% of the profits from the private capital are returned back into the foundation. We create or fund existing companies in the pre-IPO, that is non-publicly listed companies. We fund a number of initiatives as advocacy, whether it's ethics, whether it's supporting publications to look at the challenge. There's a paper just published last week by a consortium of scientists, some of whom are here, to actually look at the gaps in this field. It was published in the journal Nature Aging. And every now and then we look at this field and we ask ourselves, where's the field gone? Where's it today, and where do we think it's going to in the future? As we think about it, we actually have now grown. 5 years ago, last month, we were launched as an organization. I had the privilege of being the first employee, number 1, the founding CEO. Today, as you'll see, we operate across the world as a global entity. Where do we touch this value chain? If I think about health as a value chain, all the way to the left is public opinion. We usually, as scientists and clinicians, don't think about this. We thought about this from day one for a very important reason. If the public doesn't understand the importance of doing this, their political leaders will not get behind it and support it. We have to shape the narrative and we have to shape the conversation first and foremost in the public domain. Often we don't think about this. And in this field in particular, because there's a lot of people who actually get ahead of the data. They talk about the science in ways that the science actually isn't supported by the data. And this is a problem because what today the definition of longevity can be anything from a supplement to a sauna, to a spa, all the way through to advanced molecular genetics and research. And getting to understand exactly what we're talking about and where this field is and where it's supported and where the evidence is very critical in getting public support. And we've been working on this. Another thing we found as we did this research across the world, we asked people in North America, in Europe, and in Asia a simple question. As you get older, what is important to you? Very simple question. Almost nobody said, I want to live longer. No, almost nobody said that. They actually asked for 3 things. They want to remain mentally functional, physically independent, and financially independent. 3 things were consistent no matter which culture. Mental, physical independence, and financial independence. There was a common word there, independence. It wasn't about living longer. It was living independently as long as they're meant to be in this life. The 4th was an interesting thing that surprised us, which is I don't want to be stigmatized as old. I don't want to go to the supermarket and have a geriatric section. I don't want to go to the fashion store and have a geriatric section. I want to be part of the mainstream population. So the whole narrative of what it means to be old has changed in the consumer's mind. And one of the things I've learned over the years, it's important for us to think of these stakeholders not as patients, but as consumers. We are all consumers. We avoid trying to become patients. And so coming at it with a medical lens is actually a false narrative for the population, and that's important to think about if we're going to grow, whichever country you're talking about. Policymakers have to be part of this conversation because they fund, they support, they create the regulatory framework. Ultimately, government agencies are critical, whether it's the US NIH, the Medical Research Council in Europe, and all of this is critical. We are actively participating in every stage of this. Of course, at the center of this, academics, where all the research is done and they need to be supported and funded. This is a particular difficult time around the world in funding academia. The United States funding has been challenged at the NIH with our current administration. The UK is rethinking about how to fund, and we have to keep aging research at the center of this discussion because most of our healthcare costs are about aging-related diseases. That is a critical part of this. And I'm going to share at the end some examples of some success. Biotechs, much of the science has to go into biotechnology. By the way, there isn't a single drug that comes to market, with a rare exception of some vaccines, without the private sector. They're into single diagnostic that actually doesn't get scaled without the private sector. So while we think about the public, the academic, and the philanthropy and the private sector, in operational terms, it's one value chain. And we have to think about how to accelerate the private sector embracing this. Ultimately, big pharma is still responsible for the bulk of therapeutics, whether it's generics or branded. We still need the private sector and big pharma and biotechs, and ultimately the regulator to approve these drugs to come to market. Let me turn now to some of the areas that we're working on. Funding today from Hevolution. We have committed over $400 million US in the last 24 months. We are the second largest funder of this field now in the world, second only to the US NIH. And given what's going on in the US, I don't know. What many of you may be surprised, in particular for my US colleagues, 5 of our research grants today fund scientists who are employed by the US NIH and their intramural program. When we launched, a number of scientists said, well, you know, we can work with academia, can you work? We are actually providing grants to the US NIH researchers today. That's one. Number 2, today as I speak to you, we have about 250 researchers around the world funded by Hevolution. Across every continent except now South Asia. We have North America, South America, UK, Europe, and Far East, Singapore, not yet in South Asia. We're looking at how to move on to that. Our grantees are now contributing the future of some of them to future biotechs. The first 4 companies that I've listed here, I'm pleased to say, all 4 were preclinical when we started. Today, all 4 companies have moved into human research. So as you think about progression, one of our goals was to accelerate this field. The fact that these companies have gone from preclinical research into actual human trials tells you that the field is now progressing. We are seeing human research, and I'll talk about 1 or 2 of these in a minute. Some of the institutions represented here are funded by Hevolution. We're proud that Buck Institute was one of our first actual focused research institutions that funded, and really credit to Eric Verdon and his team, who's represented here today, because they were some of the pioneers that we were able to sit down with and come up with this collaboration. And these are a number of other partnerships that we have. And of course, we today convene the world's largest aging and health span meeting in Riyadh every other year. And I can give you an idea, the last meeting we held had 2,600 people come, 2,600 from 80 different countries. Now, what about looking to the future? We've recognized that we can only do this together if we come together. And how do we then overcome this challenge? Our research areas that we focused on, and the biotech, I'm going to take a few minutes just to give you a window into where that's going. We took an approach that we were going to fund companies, not science grants. We fund all stages of science grants. But on the company side, which many of you may not get exposed to as much, we said we're going to invest in companies that are targeting a known disease, that is scale, is global, so it can be democratized, but are attacking that disease with a neuroscience, aging biology perspective. Let me give you a couple of examples. And you'll be surprised the first example I'm going to give you. If you think about this, hepatitis B today is incurable. We have no cure for hepatitis B. Every clinician in this room will know that. We have a vaccine for it, but there are 2 billion humans, that's almost a quarter of the world's population, has been exposed and infected with this virus. There are an estimated 350 to 400 million humans walking around with chronically carrying this virus, about 15 to 20% of the population that's been exposed. They're the ones who are spreading it to other people, and they are at risk of liver cirrhosis and cancer, hepatocellular cancer, because they are chronic carriers of hepatitis B. No treatment available today. A group of scientists that we were fortunate enough to meet asked a very interesting question. What is different about the 80% of humans that get infected with the virus and eliminate it, and 20% that get the virus and can't eliminate it, and yet the virus is the same? This is very topical because COVID 90% of the deaths were people over 65. The young hardly ever had mortality, but it was the same virus. So do we treat the virus, or do we figure out what is it about the host, the infected body of the host, that is different? And one of the things you learn with HIV as a virus, and now we've learned with hepatitis B as a virus, is actually the virus accelerates the biological process of aging in the infected cell tissue. And somehow, some infected people have a faster aging process, it becomes older, and they cannot eliminate the virus. So this group of scientists came at this by saying, could we edit, not the genome, but the epigenome? So they came at it by editing the epigenome and using mice models infected with hepatitis B. They actually treated the mice not with an antiviral, but by editing the epigenome, they rejuvenated the cells of the liver in the mouse. That was then reproduced in other animals, including in primates. In monkeys, where the same experiment was done, edit the epigenome and see if the monkey will shed the virus. And bear with me, because to me this is one of the most exciting things, the way aging biology and aging research, it could potentially change our future. As I speak to you today, the first human trials of this approach to treat and cure hepatitis B are being done in humans today in New Zealand and Australia as I speak to you today. Think of the profound statement I just made. If this is successful, as it was in monkeys, as it was in rodents, if it's successful in humans, the future of medicine to treat a chronic viral infection will move from an antiviral and as a toxin to rejuvenation of the host tissue so that your own immune system can kick the virus out. That is profoundly different approach to medicine. So if somebody asks me today, how is aging research helping and how are we going to democratize? 350 million humans could benefit across every country and across because geoscientists took a different approach to treating it. That's one example. The second example I will give you is in dermatology. Everybody here either knows somebody with psoriasis or has treated somebody with psoriasis. And I'm an endocrinologist by background, if your traditional treatments don't work, then we give you systemic immunosuppressants and try and suppress the immune reactions to bring down the inflammatory process, because that's as good as we got. But if you ask the question in the psoriatic plaque, what is different about the part of the skin that is psoriatic versus in the same person, the adjacent skin tissue is relatively normal. If you start to sample this, you'll start to see an intense senescence in the skin lesion itself, in a fairly common, relatively common disease, which we don't think about as an aging-related disease. But the biology suggests the pathways are common to aging. So in this example, a group of scientists came together, built a company around it, and said, we're actually going to target the psoriasis by targeting the senescence through the skin, only in the skin lesions. That animal research has now progressed to humans. In fact, we just announced an agreement in the Middle East to do some of the first human trials that are being done as multi-center trials across the world, including in the Middle East, in psoriasis using a geroscientist anti-aging process in a known disease. Now, what is going to happen in these examples I'm giving you? I can give you others. These are just two. What is going to happen is we've been asked the question repeatedly, what is the regulatory path of bringing a drug for aging to the market? Well, the other approach is you take a drug that is known to target aging in a known disease where the aging process is accelerated or heightened, get that approval, and then start to do human trials in other applications, whether it's in the skin or in the liver, wherever you look at, because now we're seeing aging, the immune system, and viral infection are actually converging biologically, and much smarter scientists than I will come and talk to you about a lot of that later today. So the approach that my friend and colleague Matt, for example, who's going to talk to you later, has been taking in dogs is to say, how do we take a known drug that's known to have a path, overlaps with aging, but actually target the aging process? What I've just given you is built on that thinking to say, if I know a disease, and I can take it all the way, actually can do the trial in a human and accelerate the movement out into human trials. So these are exciting opportunities, and let me leave you with the concept. If what we're seeing over the last 5 years continues on the trajectory that we predict, then the $400 million investments we've made, and arguably the next $500 million we're going to make in the near future, is going to be a tiny, tiny drop in the ocean of impact. Think about 350 million humans who are waiting for some of these breakthroughs today. Think about all of the different organ systems. And so the question I will provoke you with is, how does Mauritius, given you have a unique population, well-defined, good infrastructure, excellent healthcare delivery, a developed economy, participate, and the same challenges of a declining population, an aging population, participate in this global ecosystem to become part not only of the solution, but also benefit from it relatively early in the process. Thank you very much. I'm happy to take questions.
Thank you, Dr. Khan. First question that's come in, what skills or training do you believe clinicians need most to deliver prevention-focused, longevity-based care?
So I've not practiced now in 20 years. So the first disclaimer there is my experience as a consultant endocrinologist is outdated, but I think some basics don't change. Number one, we have to remain critical, objective scientists. Assess the science. Let's not go after the trend du jour. Second, we have to keep an open mind. It's that balance of objectivity, but the courage to explore in new areas. Let me leave it at that.
Fantastic. Suggestions or ideas about practical steps Mauritius can take now to bring geroscience into use?
It's a great question, and I'll give you an example of what we found in Saudi Arabia. When we started this journey in Saudi, there was not a single geroscientist, trained geroscientist in the kingdom. Lots of academic institutions, well-funded, all the rest of it. Not one scientist was actually trained in geroscience. We took the first young PhDs, sent them to several places around the world, and actually funded their postdoctoral programs to train them as postdocs in the best centers around the world, and more will be going to actually train as geroscientists, and then found a way to bring them back so they could set up their own programs. That is key to partner with the clinicians. Typically as MDs, we don't get that training, we need both. And of course, some of the trainees we've sent were actually MDs who wanted to do basic science. And we've brought them together. Some of those are now coming back. I'll give a very quick, one of my young scientists, Yusuf, he's an amazing MD, PhD, who's decided he doesn't want to practice anymore. He's a vascular biologist, basically. And that's a perfect example of changing somebody's career. That's what we need, talent. Human capital is what Mauritius needs to build.
Fantastic. Last question for you. It has to do with the importance of data collection and perhaps tools like iCope and such. How can these help clinicians improve Healthspan in real-world practice?
Well, there's some easy low-hanging fruit. We all know it, right? Stop smoking, exercise more, calories, et cetera, et cetera. All of that is table stakes. Our public health data, and I think the US is not a good example of that because we don't really have a national public. I think the UK and Europe are good role models to be able to, if you think about what the UK is doing in the biobank, if we look at our future health in the UK, these initiatives are actually getting us to understand not only the general population, but the next level down. And I think Mauritius is an example where with 1 million people or 1.2 million people, you could very quickly get a very detailed look at this population and not only benefit, but contribute in unique ways. That's a question we're asking in the Middle East, the same question. How do we contribute to that? And I think Mauritius becoming part of that global consortia and contributing to it, but also benefiting from it is the only way small countries, whether you're Qatar, you're Mauritius, doesn't really matter, we're gonna have to do. How do we work together, I think is a regulatory and legal question. And while there are barriers, I can tell you from experience, they're not insurmountable. They have been overcome by multiple countries now to collaborate. Because the usual question comes up, it's human data, how do we pool, how do we share, it's biological tissues from humans. All of those are things we have to overcome, but don't take no as an answer. because they can be overcome. I can give you lots of examples where that's been done.
Fantastic.
Thank you very much.
Thank you so much, everyone.